你还挺准时，很好，表扬一次。
那是必须的。
Hello, Prof. Welcome.
老好，你好。哎，洪涛，你会议结束能赶到我们这边来吗？吃饭不行是吧？
可能我赶不过来，
太晚了是吧？下次吧。
对吧？就你们吃吧，下次再找机会吧。
我不说了吗？前2天我说请你吃大龙烤鸭。
下次再那个，
好，下来。
Hello, Russia.
Hello. Hi, how are you? Hi.
各位大家好。
Thank you for joining, Prof. Chen.
谢谢各位专家加入。
Hi,
Dr.
Kato, can you hear me?
Hello, Vishwas.
Hi, Raju sir.
Hi, how are you?
Hi, how are you?
Sir? Good day.
I'm fine, thank you. Have a great day.
But there is no voice from Dr. Kato.
Yeah, she'll be joining us soon.
Okay.
Somebody might have logged in. She'll join us soon. Hello, Prof. 𝘗𝘳𝑚𝑎𝑡𝑠𝑢.
Hello,
Hello, Prof. Hi, how are you? Thank you very much for joining. Yeah, Prof. 𝘗𝘳𝑚𝑎𝑡𝑠𝑢 is a speaker, I guess.
Am I the first speaker, right?
Yeah, I hope so.
Yeah. Okay, I'm waiting. Yes,
yeah, we're just waiting for Prof. Yoko-Kato to join us.
So, 𝘗𝑚𝑎𝑡𝑠𝑢 sensei.
Yeah, nice to meet you again. It's a surprise.
Sir, how are you doing?
Both of you are there.
Hello, sensei.
Yeah, all right.
How are you?
So many fellows are there.
But it's a little bit difficult for me to pronounce your name correctly. I'm so sorry about that. So first of all, for the moderator, so how can I say your name? Say it again about your name.
I'm 𝘗𝑚𝑎𝑡𝑠𝑢 from Japan.
𝘗𝑚𝑎𝑡𝑠𝑢.
Yes.
Okay.
Yes. Thank you.
𝘗𝑚𝑎𝑡𝑠𝑢.
Professor 𝘓𝑢𝑚𝑖𝑛𝑡, 𝘗𝑚𝑎𝑡𝑠𝑢.
Yeah, nice to meet you.
The Chinese translation will be 小松文成.
Dr. Chen. Yeah.
Means a pine tree.
Yeah. Yeah, the same meaning, Chinese character.
That's your family name, right?
Yeah, right.
Is that correct? 𝘗𝑚𝑎𝑡𝑠𝑢, Dr. 𝘗𝑚𝑎𝑡𝑠𝑢?
Yes, correct. Thank you. Thank you, Professor. I'm 𝘗𝑚𝑎𝑡𝑠𝑢. Yes.
Okay.
Welcome to our seminar. Welcome to our online seminar.
Yeah.
So first, I'd like to
We'll just wait for Prof. Kato. Maybe
no, it's not. It's a kind of unofficial gossip.
Okay. Please.
Our program started from 2018, which is 6 years ago. So now it is the longest series program in China, in the Chinese Neurosurgical Society. So every episode we have about 6,000 to 8,000 audience.
Oh, really? So
which
many
is a lot.
audience
Which
there.
is a lot. So
How
today,
many do you expect today?
Pardon?
How many participants do you expect today?
Today, I
Almost same.
suppose in I
6,000.
suppose in the China in
I would like to
all over
say-
the Grand China area, there will be over 8,000. Over at least 8,000 audiences.
At least
I
8,000.
sincerely hope today we can go beyond 10,000
So many.
today.
So our program name is the Precision Neurosurgery Intercity Express. So which means every episode will be hosted in a city. In the last 5 years, this program was hosted in almost all the major cities in China. And this year, we started from Hong Kong, Macau, and Taiwan. So today's episode is the first episode for us to go abroad to Japan, right? Also, the first episode
for
in
me.
Japan.
Oh, thank you for the invitation
So
today.
that's the honor is ours. We are very honored to have Professor Kato, Professor 𝘗𝑚𝑎𝑡𝑠𝑢, and other professors and friends as our guests to participate in this great event, right? And also, it is our pleasure and honor to have Russia as a representative of the ACNS here.
Prof. Kato has joined us. Hello,
please
Prof.
welcome Professor Kato.
Hi,
Hello.
how are you? Hi, Dr. Chen.
Good,
Thank you
thank
very
you,
much
thank
for
you.
organizing this wonderful webinar.
Yeah, thank you very much.
Yes,
And your old
recommend
friend, Professor Banan Xu, is
Yes,
also
and
on.
we met
Hi,
so
你好，
many
你好，
times.
谢谢。
So how are
And,
you, Dr. Kato? You are our old friend of China.
Yes.
Yes.
I'm very
I
honored.
remember once Professor Xu write on a note, "tough woman" in Chinese, and give it to Professor Kato. Professor
Yes,
Xu, do you still remember that?
You really did a great job, you know, especially for the cerebrovascular area.
Thank you so much. Thanks so much. So, Dr. Chen, and so many excellent teachers. So today I recommended the 3 doctors from my colleagues.
Yes.
One is Professor Komatsu Sensei and Professor Nakahara, and also another is Professor Takai 𝑘𝑎𝑦𝑢 Sensei. So you can be the please MC today.
Yes. We are very interested in the 3 professors' lectures. So we offer our experience for the VR and mixed reality simulation in the case of trigeminal neuralgia and hemifacial spasm after Professor 𝘗𝑚𝑎𝑡𝑠𝑢's lecture. Okay.
Okay.
So
The first.
time is up. So shall we start?
Yes, I think so. So you be the first speaker, Dr. Chen.
Okay. Please allow me to introduce briefly in Chinese to the Chinese Neurosurgical Society,
Of course,
and then English. Okay. So 好，那咱们节目开始了啊，各位观众、各位听众，今天啊，咱们很荣幸，我们的这个精准神外城际直通车呢，第一次啊来到了海外啊，咱们跨海列车直奔日本。今天咱们是叫日本名古屋站。那么今天非常荣幸啊，我们的节目也是跟亚洲神经外科学会一起举办的。那么这个首先呢，我们稍后啊会跟大家先介绍我们的主席和来访的这个嘉宾啊。那么那我下面要问候啊，就叫皆さんこんにちは，是吧？然后 Hello everyone. Today it is our honor and pleasure to have all our friends from the world to participate in this event. Our event is called Precision Neurosurgery Intercity Express. this is an official program for the Precision Neurosurgery Society of the Chinese Research Hospital Association. So today, it is my honor to introduce you our two chairperson, so it should be chairpersons. So first is Professor Bainan Xu from the Chinese PLA General Hospital. Please, Professor Xu.
Hi, good afternoon for everyone. Welcome to join the meeting.
Okay, thank you, Professor Xu. The next chairman is Professor Yuko Kato from Fujita Health University, Japan. Please, Professor Kato.
Hi, 你好，大家好。
Great.
Thank you very much for invitation for all of us. Thank you very much. We look forward to your the great lectures next 1.5 hours. Thank you very much.
Thank you very much. Okay, today's event is a joint web meeting hosted by the Asian Congress of Neurological Surgeons and the Precision Neurosurgical Society of the Chinese Research Hospital Association. Professor Kato is president of the ACNS, and Professor Bainan Xu is the president of the Precision Neurosurgical Society in China. So today we have 4 topics. I will introduce Japanese representative. First is Professor Fuminari Komatsu from the Fujita Health University. Please, Professor Komatsu.
Thank you. Thank you for the invitation for this webinar. So it is my pleasure, great pleasure to be a speaker today. So can I start my presentation?
Later, please.
Later. All right. Just for the greeting. Just greeting.
Okay. Thank you. The next speaker is our other representative is Professor Nakahara from the Fujita Health University. Please, Professor Nakahara, please.
Hi, can you hear me?
Yes. Loud and clear.
Thank you very much.
Much.
My name is Ichiro Nakahara. I'm talking about the treatment of the acute treatment of the subarachnoid hemorrhage. I mean, the ruptured angle later. So it's a very, very great honor for me to hear.
Okay, thank you very much.
Thank you.
Our another representative from the Japanese neurosurgical community is Professor Takayuki Hara from Tokyo. Professor Hara, are you?
Okay. Can you hear me?
Yes, loud and clear. Thank you.
Thank you for giving me a good, very nice chance to speak here in this good webinar. And it's a great honor for me. And my hospital is Toranomon Hospital, located in Tokyo. And I'm a general neurosurgeon doing skull-based surgery and cerebral vascular surgery. And today I will talk about the intraoperative imaging for the cerebral vascular surgery later. Thank you.
Thank you very much. And besides, we also have friends from the ACNS, like Dr. Liu and Dr. Rasha here. So first, I would like to invite Professor Xu to give us a brief welcome speech. Please, Professor Xu.
It's my great honor to have this meeting for this sort of international communication. This is the first time for us, even if we have this program for at least 5 years already. But today, I really so excited to have so many international area expertise to join us to have this great, wonderful meeting. And also, not only the Dr. Kato, we have so many other new faces. So today I'm so happy. And in addition, we have the Chinese, also the expertise. For example, the Dr. Pan Peng and also Dr. Hong. So today we expecting this meeting have a wonderful, successful outcome.
Okay, thank you very much, Professor Xu. Next, I want to invite Professor Kato to give us a welcome speech. Thank you.
So thank you very much for this opportunity for all of us. And I think that the friendship in between the China and Japan is very, very important and more dense in the future. The Chen, can I a short introduction of the Professor Komatsu?
Okay. We have also invited discussion today. They are Professor Wai-San Poon from the Hong Kong Chinese University. Professor Poon, are you here?
Hello. Yeah. Hi. I'm here. I'm privileged to be here too, listening to all the old friends speaking. Thank you.
Okay. Thank you very much. And another VIP guest is Professor Tao Hong, who is extremely famous endoscopic specialist in China from Nanchang University. Professor Hong, are you here?
Good afternoon. Yes, good afternoon. It's my honor to attend such an international webinar. And I'm so happy to meet Dr. Kato and Professor Xu and other colleagues on the net. So I'm so happy to attend such a great webinar. Okay.
Thank you very much. Okay, I believe today, after the first presentation by Professor Komatsu, Professor Hong will have I'm expecting your opinion and to this topic. So now we started from the first topic by Professor Komatsu, which is the pure endoscopic management in the case of trigeminal neuralgia and hemifacial specimen. Please, Professor Komatsu.
Thank you.
Okay.
Thank you again.
So can I introduce Komatsu Sensei?
Okay.
Short introduction.
Please. Sorry.
It's okay. So the Komatsu Sensei is the graduate at Tokai University, 1998. And he studied not only Japan, but also the India, Kolkata, 2018. And Komatsu Sensei joined us since 2020 to our university. So his the skill of the pure endoscopic approach is outstanding. So everybody knows. And he does more than 150 cases per year, especially for the microvascular decompression. I think you will listen carefully and maybe he can wait the questions. Please.
Thank you. Thank you for the interaction, Professor Kato. It's also my great honor. So I'd like to share my presentation. Can you see my slide?
Yes.
Okay.
Yes.
Thank you.
Very clear.
Thank you. So I'd like to start my presentation today. My topic today is the endoscopic microvascular decompression for trigeminal neuralgia and the hemifacial spasm. So this is our hospital. It's in Nagoya City, in Japan. It's almost it's located almost center of Japan. The hospital itself is not big, compact, but so many neurosurgical patients come to our hospital. And I also studied endoscopic anatomy more than 10 years ago in Vienna, Austria. This is I learned the basic knowledge of anatomy and the basic technique of the endoscopy here. And also I have experience of the clinical experience in India, in Kolkata, Institute of Neurosciences, Kolkata. This hospital has 3,000 cases in a year, so I also had a lot of the endoscopic cases there. So again, my topic today, the endoscopic microvascular decompression for the trigeminal neuralgia and the hem facial spasm. And I think the successful microvascular decompression requires two elements: precise identification of the neurovascular conflict and appropriate decompression. So the endoscope provides a panoramic view even in the deep surgical field with minimally invasiveness, and the transposition technique is a desirable method for long-term outcome. So this is our method, the pure endoscopic microvascular decompression. The patient is placed in the past position, and 3 to 4 centimeter skin incision is made. And 1.5 centimeter keyhole is created at the transverse sigmoid junction. The endoscope is fixed on the pneumatic endoscopic holder, and the single shaft instruments are used for the operation. The brain retractor is not used, and continuous hearing monitoring is performed. And the 4K endoscopic system with ICG is used for the operation. This is the photo of the during the operation. So endoscope is fixed on the pneumatic endoscopic holder, and these are the instruments I used operation during the operation. And the decompression method, there are two decompression methods. It's interposition and transposition. As you know, that the interposition, it's place the processes between the cranial nerves and the offending vessels. In contrast, in the transposition method, the offending artery is moved away from the cranial nerves. And it is said that in the literature, the transposition provide a better outcome for the long-term outcome, for the long time. And also, we basically do the transposition technique, but we don't use the processes. Only the offending artery is fixed by the fibrin glue. I think this is the suitable for endoscopic technique. So I showed some illustrative cases. The first case is the trigeminal neuralgia, left side. On the right side picture, the trigeminal nerve is compressed by the SCA. This is one of the typical case of the trigeminal neuralgia. So video is shown. The patient is placed in the park bench position. Skin incision is shown, and this is the small craniotomy, and then the endoscope is inserted. Now we can see the trigeminal nerve, and the nerve is compressed by the SCA. The ICG is given. We can see the offending artery well, and the arachnoid around the trigeminal nerve is dissected. And here is the offending artery, SCA. So this artery was moved away from the trigeminal nerve and fixed on the, here the tentorium, fixed on the tentorium with fibrin glue. So secure decompression was observed. This is the end of the surgery. This is the before and after the decompression. The patient symptom recovered well after the operation. This is another case. Also the left side, the trigeminal neuralgia. In this case, the petrosal vein is well developed and disturb the view of the trigeminal nerve. But in such cases, the endoscope provides a better view than microscope. So even the petrosal vein, we can see the offending artery compressing the trigeminal nerve. Again, this offending artery was slowly moved away from the nerve and fixed on the tentorium with fibrin glue. So complete decompression was also confirmed with complete preservation of the petrosal vein. This is the case of the trigeminal neuralgia caused by the trigeminal cerebral artery. Trigeminal cerebral artery, one of the variant artery of the posterior fossa. So let's see the video. This is the right side. We can see the trigeminal cerebral artery, and it penetrates the trigeminal nerve near the Meckel cave. SCA is also involved in the compression of the trigeminal nerve. So the SCA was decompressed initially in this case. And also the proximal side of the trigeminal cerebral artery was mobilized and attached on the dura. But the decompression was incomplete. So the interposition was added in this case. And then this part of the trigeminal cerebral artery was also mobilized and attached on the tentorium again. So by this technique, the complete decompression was done, even this in this complex case. ICG is given, the patency of the artery was confirmed. This is the pre and the post surgical views. And then the hemifacial spasm. This case is the right side hemifacial spasm. ICA is offending artery on the 3D image. So the patient is again in the Parkman's position and the skin incision made. Same as the trigeminal neuralgia case. This is the keyhole and the endoscope inserted to the dura. So we can see the 7-8 nerve complex and the cranial 9. And the 30-degree endoscope was inserted. The ICA is running on the facial nerve. So this offending artery ICA was separated from the facial nerve and touched on the dura again with fibrin groove. So we can see the indentation on the facial nerve, and the facial nerve is compressed, completely decompressed with preservation of the perforators. We can clearly see the pontomedullary junction and also see the cranial nerve 6. This is the pre and post surgical view. Next case is the facial spasm. The offending artery is a vertebral artery. So skin incision is same as the previous cases. And keyhole is made. So again, the cranial nerve 7, 8, and 9 are identified, and we can see the vertebral artery running on the facial nerve. ICG is given now. So this vertebral artery is mobilized and lifted and attached on the dura and fixed with fibrin groove again. So by this technique, the facial nerve is completely decompressed. We can see the indentation on the facial nerve. This is the pre and the post surgical views. So in last 4 years, we had approximately 500 endoscopic microvascular decompression cases. So mainly in the trigeminal neuralgia cases, and then facial spasm. The surgical result, this is the surgical result in last year, in case of the trigeminal neuralgia. 90%, approximately 90% of the cases are recovered well. And some cases are idiopathic trigeminal neuralgia. It means that the arterial compression was not observed, and the internal neurolysis is the incision on the nerve. was performed, and in such cases, the 70% of cases were recovered well. As for hem facial spasm, 88% patient are controlled spasm very well. And the complication, for microvascular decompression, hearing impairment is important complication. And in our series, hearing impairment was 1.6%. And also the CSF leakage was so low, only 0.6% was confirmed CSF leakage. So for discussion, for the microvascular decompression, so we used the endoscopy, but microscopy historically had a lot of the evidence compared to endoscopy. But nowadays, some literature, especially from China, reported the advantage of the endoscopy, and it says that endoscopic microvascular decompression is better than microscopy. But in contrast, other literature said that between the endoscope and the microscope, the surgical results are almost same. So it's still controversial. I cannot say today that this feature is better for the microvascular decompression. But another literature said at least the endoscopic microvascular decompression is less invasive. So that's why the post-operation headache is significantly lower compared to the microscopic surgery. So I can agree the less invasiveness of the endoscopic surgery, but we have to discuss much more the surgical result compared to these two methods of the microvascular decompression. Thank you. This is the end of my presentation.
Thank you very much, Professor Komatsu-sensei. So, Dr. Chen, please go ahead.
Okay. A great presentation. Thank you very much for your great ideas. And I want to invite Professor Tao Hong to give some comments to this presentation. Thank you.
Okay. Excellent presentation. We can see their wonderful operation. Use the endoscopy. Still, my question is, we know the endoscopy has a wide operating view, and we can close observe the structure. So compared to microscopy, the advantage of the endoscopy is obvious. But we also know the endoscopy has some other disadvantage. For example, it is 2D, and we can't see the area behind the endoscopy. So, my first question is, did Dr. Komatsu has any case to injured the petrol vein when you perform the operation, like the lesion on the crevice? We need to put the endoscopy much deeper. Do you have any case injured the petrol vein? This is my first question. The second question is that compared to microscopy vascular decompression, the result is not significantly improved compared to microsurgical operation. So we know the endoscope has a wide view, we can see more structures, maybe can observe any vessels neglect. But more neurosurgeons in China, when they perform such kind of operation, they still prefer to use microscopy because they said you can use endoscope, but endoscope did not significantly improve the result. So, what's your opinion about this this view? This is my question.
Thank you, Professor. Thank you for question. As you said, I think for the observation, endoscopy has a big advantage, but manipulation is difficult compared to the microscope. So the endoscope has some disadvantage. It also has the disadvantage compared to the microscopic surgery. And the bleeding from the petrosal vein is also the difficult issue for the endoscopic surgery. I also explained some cases, not so many, but some cases of the bleeding from the petrosal vein. But the bleeding from the petrosal vein, basically the venous bleeding, it is managed by the compression with a hemostatic agent. Not so difficult. Just put some side cell around the petrosal vein. It's not difficult to control the bleeding from the petrosal vein. So yes, I have some experience, but for the endoscopic surgeon, we have to manage such bleeding, even such cases. And the second case, I think the surgical result, it's not significantly better than the microscope. Yeah, it's also correct, I think. So some cases, for example, some cases the cistern around the trigeminal nerve is so very narrow, very small, so difficult to decompress. And also even after decompression, another case, the adhesion happen sometimes. So also cause the incomplete cure in such case. So I think the problem itself is not endoscopy, not microscopy. How can I say, the characteristic of the disease itself. We cannot completely overcome such problem, even under endoscopy and the microscopy. This is my opinion.
Yes. So I have another question to ask you. You use the fabric glue to fix the artery, the vessel. So how many times it can last to fix the artery? Is absorbable? Is absorbable?
Yeah, absorbable. Yes, yeah, you're right, absorbable. But I showed the video very short time, but I dropped several fibrin glue on the vessel. So also the important thing is we have to expose the dura completely, dura or tentorium completely, and the vessel is attached on the dura or tentorium for long course, not in the one spot. The vessel should be, I can say, fixed on the long attachment.
After the glue absorbed, it will probably be returned back to compress.
I think yeah, it's not. Yeah, I saw some cases, the recurrent case, but it was not removed. It become also adhered on the dura with probably the connective tissue. Become the connective tissue.
Okay, thank you very much. Thank you for your explanation.
Dr. Hon, can I add to your Komatsu-sensei comment? I am of course microscopic neurosurgeon, but recently I joined his cases, so many cases. But the patient satisfaction, because this is very, very less invasive, because it's magnification and also illumination and also resolution is very high comparing with the microscope, because I did so many microvascular completion by microscope, especially the seventh nerve. We can see very clearly with the endoscope. because with a microscope, it's quite difficult because so many the muscle they so sometimes we cannot see the seventh nerve is quite difficult, and also everybody suspicious because some adhesion you mentioned about because it's absorbable. But I never see it's detached of the wall, and also the long enough. The adherence part is long enough, not one part. Maybe I think it's 3-4 months or sometimes half a year. It may organize with Dura, I think. Thank you very much for your comments.
Thank you, Professor Kata. Thank you.
Okay, great discussions. I want to invite Professor Xu to give some comments for this great presentation. Professor Xu?
Okay, so very nice talk. And I just have a very small point for my curious. So nowadays in Japan, the endoscopic technique and also the microsurgery to deal with this MVD. So in Japan, which way is
more popular?
Majors right now?
Thank you for your question. I think still the most of the neurosurgeons do the microscopic surgery. Only limited neurosurgeons do the endoscopic technique. That's the Japanese situation right now.
Okay, it's 1/3 for the endoscopic?
No, not like that. Only the few neurosurgeons do the endoscopic surgery.
Okay. Okay, thank you very much. Very nice.
Thank you very much.
Okay, because I know there are more comments and questions there, but because our time is limited, so we will move on to the next topic. I selected this topic for as a complement for Professor Komatsu's presentation, because next I will share with you our experiences for the virtual reality simulation and the mixed reality simulation in the case of trigeminal neuralgia and hemifacial specimen. So please allow me to share my screen first. Okay. So I'm Dr. Chen from Chinese PLA General Hospital. We started this program, which is virtual reality and mixed reality simulation for trigeminal neuralgia and hemifacial specimen back in 2012 with the supervision of under the supervision of Professor Bainan Xu. And the background is like it says follows. First, I want to briefly introduce you to several concepts. The first one is very popular and very well known, which is VR, means virtual reality. The second is AR, which means augmented reality. The third is mixed reality, which is quite popular in the recent years. For example, the Apple company just released their mixed reality device, which is called ProVision. They call it's a spatial computing device, which is actually a mixed reality device. And the fourth concept is XR, which is called extended reality, which is included all the VR, AR, and MR. So that's a basic concept. So then, why we want to use this technique to simulate the neurovascular confliction in the case of trigeminal and hemifacial trigeminal neuralgia and hemifacial specimen, because the precise preoperative evaluation of the characteristics of the neurovascular confliction is very crucial for surgical planning, outcome prediction, and shorter operation time in the microvascular decompression surgery. So traditionally, we use a conventional structural MRI to do the evaluation, but it is insufficient to depict the neurovascular relationship. I will show you the case later. And so we want to use, we try to use virtual reality and the mixed reality to offer a three-dimensional multimodal information simulation for the case of trigeminal neuralgia and the hemifacial specimen. So the first project is about the multimodal imaging-based virtual reality simulation in the case of neurovascular confliction. We published this project back in 2018 in World Neurosurgery. First, let's see an illustrated case. This is a 65-year-old male suffered from left hemifacial specimen for 20 years. And the patient tried every several kind of therapy, including the Botox injection, but it failed. All the other treatment failed. So he want to do the microvascular decompression. And if we check the structural 2D or a structural MRI image, you can see even with superfine three-dimensional reconstructible space sequence, we cannot see the offending vessel and then the nerve in the same time very clearly. And this is a 3D ToF MRI. We can see possibly this is an offending vessel. But in this, the problem with this sequence is, in this sequence, we cannot see the nerve clearly. If we change to another level, we still cannot see the offending vessel and the nerve clearly at the same time. But if we use a virtual reality, use a VR simulation to do the job, we can see clearly the offending vessel. This is from the ICA and compressed the seventh nerve, the root anterior zone. So if we can also rotate the VR models so that we can simulate the surgical approach. So from this suboccipital approach, we can see the offending vessel is compressing the REZ zone by the seventh nerve of the seventh nerve at this level. We can also use some real-time open source software to simulate. You can see this is from the frontal view, and we can simulate the surgical approach. We can simulate flying in to the surgical field and check the root anterior zone and the offending vessel from all around the nerve, right? In this case, we have several advantages. First, we do know the exact position where the offending vessel compressed the root anterior zone. The second is we know if there's only one compression here or two offending vessels here, right? Because in about 10 to 20% of the patients suffering from hemifacial specimen or trigeminal neuralgia, it's possible to have two offending vessels at the same time. So traditionally, without the virtual reality simulation, after we did compression one offending vessel, we should routinely to check the other place around the REZ zone of the seventh nerve. And this kind of so-called beat around the bushes manipulation will possibly cause complications. So in this case, we save our surgical operation time, and we also avoided the excessive exploration and lower down the complication rate. So we can also import this kind of ear model into the mobile device like the iPad. So it is very useful. You wanna talk with the patient himself or the patient's relatives to discuss clinical risk. So this is VR simulation. Later on, we will try to report the model iPad. Of course, this is another thing. Let's show the thing. I'm starting to do. Okay, this is iPad. With the iPad, an iPad can easily use finger to rotate and to moving out. It is very straightforward. We discuss this through the video. With that. So just like just a minute. So if you notice that I am now holding this it's not clear. It's obscured by the Zoom meeting software. Okay, anyway, we also developed some touchless manipulation for the intraoperative use. For example, intraoperatively, during surgery, if you want to recheck the offending vessel, you can just use the finger to point and to rotate the model and to check the offending vessel. So this is for dedicatedly for the surgical use, intraoperative use. And you can also check the original image. For example, the DICOM image. It rotates and checks a different level. So now we have the full control, touchlessly, full control of all the patient's data set and the virtual reality model. Okay, so we intraoperatively, back in that previous case with a hemifacial specimen, intraoperatively, we found the loop is exactly coincide very well with virtual reality simulation preoperatively. This is offending vessel compression, compressing the REZ zone. So we performed the decompression with the Teflon colloids, and then the patient got cured. So this is 1 week after MVD, the patient's hemifacial specimen has already completely gone. And now we followed this patient up for 5 years, and the patient got no recurrency and no other new neurological complication, deficit. So after this virtual reality project, we want to move it much further with, we want to present the neurovascular confliction models in a more vivid way. So we tried to do this mixed reality simulation back in 2000, start from 2017. So this is a technical workflow of the project. And so at first we used HoloLens 1 by Microsoft. The hardware is from Microsoft company, but we developed the software and we coded the whole project. So let's see now this is we call multi-user internet-based simulation, mixed reality simulation of the trigeminal neuralgia and the hemifacial spasm of the neurovascular confliction. So first we start our we call it pre-surgical planning client app on the HoloLens, and then we will create a meeting room or a consult room, meeting room, and then we scan this positioning pad. So we use this, the creation of Adam, which uses famous painting by Michelangelo to contribute to the hidden neuroanatomy information inside this painting. So now, this is a real patient's neurovascular model here. So we have this panel here, mixed reality panel here. Now we have one user. Okay, now we can perform all the manipulation on the model. And the other user can use either another mixed reality device or iPad or an iPhone to watch and to discuss this patient at the same time. So in the small screen, this is the screen capture video from the iPad. So we are now looking at the same patient, just the previous case, suffering from the hemifacial specimen. You can see clearly the offending vessel, the nerves, and the basilar and the vertebral artery. So the user can rotate this hologram and to do other to perform the zoom in, zoom outs, and other manipulation for this mixed reality models. For example, you can add an arrow here. You can add an arrow here to show that's a seventh nerve. And you can add a circle here to say this is a offending vessel compressing the REZ zone. And we can also communicate between users with the voices. And all the markers we added on the hologram will be updated at the same time on the other users' mixed reality device or iPhone or iPad screen. So this is a real-time internet-based education and a training tool. You can also fade several certain model. For example, in this case, we want to fade the vessels and left the brainstem here. Okay, now we faded the brainstem and left the vessels here. And this system can also use other models like for example, the tumor or other neurosurgical disease. Okay, now the first user can pass control authority to other users so that they can discuss online. For example, now the user 3 who use an iPad to participate in this discussion will see this screen, and he can also mark the offending vessel and other thing on this model. So now this screen is by the iPad, and this is a HoloLens screen. You see, in this way, we can have real-time interactive discussion between different users for the case of trigeminal neuralgia and hemifacial specimen. Okay, because time is limited, we will show the video here. And so this is our results. For this project, we checked 10 cases of the trigeminal neuralgia and the hemifacial specimen, and to check for the trainees. Most of them are residents or the new promoted attending doctors. Then we found the exploration strategy for the microvascular decompression in 48 0.3% of the cases they changed. So for this 10 case, every case we will ask 6 participants to fill in a lot of questionnaires, and later we found nearly half of them changed the exploration strategy. So which means this simulation has very significant clinical impact on the exploration rates, exploration strategy. So we published this paper this year on the neurosurgical focus. If you are interested, you can check the paper for the technical details. So we still, after this project, we still want to keep the ball rolling. We want to develop the new low-cost, light-weighted mixed reality device. So now we have a simplified workflow. We have light-weighted mixed reality device like this one, and we have low-cost device like this one. Okay, last year we tested this mixed reality back in Xinjiang in a very primary medical care hospital. We found that this newly devised device has several advantages. First, it's a separated parts design with a standard Android devices. So it lowered down the weight on the doctor's head. For HoloLens, it is quite heavy. You wear it on the head for 3 to 4 hours. You got neck pain. So now we separated the device here, and this is a mixed reality display device with SLAM sensors there. So it lowered down decreased the weight. Now it's only half of the weight of HoloLens 1, and it's made in China. And in this way, we want to lower down the cost as well. And the conclusions are as follows. First, it's technically feasible for virtual reality and mixed reality simulation for trigeminal neuralgia and hemifacial spasm. And we found it effectively helped neurosurgeons in patient-specific training for neurovascular confliction because we can have real-time online discussion, and the trainee can be instructed by an experienced neurosurgeon as a trainer in the same consulting room. And it's easy to use and has very low cost. It's helpful for institutions with limited medical and educational resources. It may have broader applications prospects in neurosurgery. For example, we can also use this mixed reality device for the discussion or the planning or the training for brain tumor surgery or other applications. So we think the future is very promising. Thank you very much for your participation. Thank you again. Oh. So please, Professor 𝘗𝑚𝑎𝑡𝑠𝑢, I'm not sure if our technique will be
thank you
a little bit interesting
for your presentation. I think that, yeah, I definitely agree that virtual reality, it gives us the better understanding of the neurovascular compression. And also, I think that this technique is also available for the craniotomy. I mean, the craniotomy of the microvascular decompression. The precise identification of the sigmoid sinus and the make craniotomy is sometimes difficult. I have a lot of experience, but sometimes miss the location of the sigmoid sinus. So do you have any experience of the virtual reality or the mixed reality for the craniotomy of the MBD? I think the mic is off.
Sorry. That's a good point. Actually, for the craniotomy, you mentioned almost the most important thing is location and the localization of the transverse sinus and the sigmoid sinus, because we want to perform a craniotomy just near or very close to that sinus. So our mixed reality can be applied for this application. We have another project which is use the same or similar technical workflow to do the mixed reality navigation. And we published this paper back in 2021. Again, in neurosurgical focus. So if you're interested, you can check that.
Thank you.
To do that mixed reality navigation, we need to adhere at least five markers at the head of the patient and scan the patient and to perform the mixed reality navigation. And with that, we developed one positioning tool, a very simple plastic 3D printed device, and you just use that navigation tool to point 5 points, and then with the mixed reality device, you will see the hologram of the sinus overlaid on the position of the patient's head. And then you can design the incision and perform the craniotomy. So that's
how is the precision of the virtual reality compared to navigation system?
Yes, very, very good point. In our project, we got the distance error, the distance error is 4.1 millimeter. So it's still, we have to we are still working on it to improve the data. But 4.1 is acceptable for the localization for the sinus, I do think. Thank you.
Thank you very much.
Okay, thank you, Chen. Very nice module, because it's very good for the educational point, I think. So we want to ask Professor Wai-Pun, do you have any comment for Dr. Chen presentation?
Please, Professor Pun.
Thank you. I'm impressed with both, really, that the endoscopic work is also making you look more and better. But one question I always wonder is that endoscope usually is associated with long operating time. I'm not sure whether the experienced endoscopists, Dr. Hong and also from Fujita, whether that's still true or not. The other thing would be that when you're wearing a lot of glasses, it made me worry about introducing infection at surgery. So I just wonder whether this training or simulation, whether if you make it as a preoperative planning, whether that will help us learn more already before surgery, so that at surgery you don't have to fiddle around with so many things. But then the downside is that you will waste a lot of material for the 3D printing and making the model, etc. So nowadays technology is moving so fast that I think we still need time to prove whether an endoscope is better than microscope, or to have the virtual reality or mixed reality can really make us wiser before surgery. I'm just throwing a few points for both Dr. Chen and Dr. Kamaka to think about this new technology moving so fast beyond my catching up. Thank you.
Thank you very much. So
I would like to, in addition to have this sort of comment. So for this technique, nowadays the AR technique is so popular. So AI, and they use a different field. And also the VR and AR is sort of AI technique. But our purpose you try to find out where is the conflict between nerves and vessels, and find out the offending vessels to deal with that accuracy and precisely later on. So that is, I think, that is a basic point for this technique. But for example, nowadays we did the MVD, and most of the patients we just based on the patient presentation, and there's symptoms, but we lack of the evidence for the conflict between the nerves and the vessels. So I think probably that is most important in this technique. If we can find out pre-operatively where is offending vessels, probably we can high up our surgical outcome.
Yes, I do agree. Thank you very much. And for Professor Pu, I'm gonna say that I completely agree with you that we are now use this mixed reality system only for pre-operative planning, training, and education. It's not for the intraoperative use. Because intraoperatively you are either with a microscope or endoscope, so you have no way to wear this. But if we want, it's possible to wear one mixed reality device to check the hologram again to make sure where the offending vessel is. That is possible, but we never use it that way. Thank you very much.
I think we should focus on preoperative diagnosis, use this technique, not for the manipulation intraoperatively. So otherwise, it's time consuming. That is the main issue nowadays. We have not solved it yet.
Yes.
Thank you. Thanks very much. Oh, maybe should we proceed? Chen?
Okay. So because the time is limited, we will move to the next topic. Next presentation will be shared by Professor 𝘓𝑒𝑚𝑒𝑗 Nakahara from Fujita Health University. The topic is very interesting. It's a new standard for the treatment of ruptured cerebral aneurysms, treatment strategies, prioritizing endovascular therapy and the future directions. Very interesting topic. Please, Professor Nakahara.
For his talk, just I want to introduce a very brief introduction of him. The Nakahara Ichiro Sensei is our member of our university. So he graduated Tokyo Medical and Dental University 1983, and he went to the Kyoto University Medical School, and he studied at the research fellow, interventional neuroradiology department of the radiology, Massachusetts General Hospital, Harvard University, Boston. And since 1998, he studied at the National Cardiovascular Center, and 2007 to 2015, he worked at the clinical professor, the Department of Neurosurgery, Kyoto University. Since 2015, he moved to the Fujita Health University. Then this April, from this April, that he joined our department. So he is, of course, everybody knows, he's one of the top, the endovascular neurosurgeon, not only in Japan, also in the world, at least. And also he's going to talk about the SH, but his most interest is WEB. It's a very recent device of the endovascular treatment of the aneurysm. So we expect his lecture, please.
Thank you very much, Professor Kato, to introduce me. And it's my pleasure to join this meeting. Thank you very much, Professor Chen, to invite me to this meeting. In Japan, and most of the endovascular treatment for the neurovascular disease is done by neurosurgeon, probably more than 90%. So, but I don't know much about the situation in China, so I don't know if the audience will be interested in my talk. But my talk is regarding the treatment of the acutely ruptured cerebral aneurysms. Recently, usually done by endovascular treatment in many cases. For the convenience of the audience and due to the limited time, I made a pre-recorded PowerPoint presentation today, and so the much younger gentleman in my PC will speak from now on. So please watch this video.
Sorry
about that. Okay. Okay, so I'm going to talk by myself. I made a pre-recorded file, but I don't know the reason why the wait a moment. Okay. So okay. Just a moment. Oh.加藤先生、今私の声が聞こえていますか？
先生の今のナレーション聞こえてます。
あ、そうですか。
ビデオの音声が今。
はい。
今はまだ聞こえてないです。
聞こえてないですか？
今まだ聞こえてないです。
聞こえてない。あ、そうですか。そうです。ちょっとお待ちください。すいません。そしたら。
じゃあ、原先生先行きますか？
そうですね。すいません。申し訳ありません。じゃあ、消しますので。
行きそうですか
？3、4分かかりそうです。すいません。申し訳ないです。加藤先生、もしよろしかったら原先生に先にしていただければありがたいですけど、すいません。
Dr. Chen, so maybe we switch the speaker from Nakahara Sensei to Hara Sensei.
Okay, yes. Sorry for this technical problem. So we move on to the next speaker, Professor Hara. Professor Kato, could you please introduce Professor Hara to the audience? Thank you.
Okay, thank you, Chen. So Hara Sensei, Takayuki Hara Sensei, graduated Tokyo University in 1995, and he studied so many long life in Tokyo University. And since 2010, he moved to the Toranomon Hospital, Tokyo, Japan. His specialty is cerebrovascular surgery and brain tumor surgery. He's a very skillful the neurosurgeon. I admire his technique, the skill. And so, and also, we are very proud of him because he got so many awards. So one of them is alumni award of the Tokyo University, and 2020 award of Japanese Society of Cerebrovascular Surgery. So I think we expect his lecture. Hello, Sensei, please.
Okay, may I start my lecture? Everyone, can you hear me?
Yes, yes, loud and clear.
Thank you so much. Okay, okay. May I share my slide? Okay, let's start. Thank you for your kind invitation, kind guidance for to my great, wonderful lecture, and thank you for your kind introduction, Professor Yoko. And my name is Takayuki Hara, and I'm now working in the Department of Neurosurgery in 𝘓𝑒𝑟𝑎𝑙 Hospital, Tokyo, Japan. Briefly, I will introduce my hospital. My hospital is located in the Tokyo city, very close to the Imperial Palace and the Tokyo Station. And my team has 6 members, including me. And as Professor Yoko Kato said, I mainly do the general neurosurgery, not only the cerebrovascular, but also some benign, sometimes skull-based surgery. Today, I would like to talk about the intraoperative imaging in the cerebrovascular surgery, especially focusing on the 3D CT angiography. And as you know, there are several complications, surgical complications in the carotid endarterectomy CEAs. So especially for the focal or local complications, we sometimes experience vessel rupture after vessel closure, and sometimes we have some problem after closure, like mural thrombus formation just below the suture site. And sometimes if we use the internal shunt, we may experience dissection in the distal internal carotid artery. And also sometimes we cannot identify the malsuturing after ICA closure. And some reports have shown that internal shunt can make dissection in the distal internal carotid artery. In this artery, here is the dissection site, and also in this another article, they found ICA dissection after the insertion of the internal shunt. And also this kind of mural thrombus formation just after the vessel closure, it can be found out. It can be found with intraoperative angiography or intraoperative ultrasound echo sonography. And so this systematic review and meta-analysis demonstrated that angiography and ultrasound sonography can give me some benefit for the outcome of the CEAs. So according to the German and Australian guidance of CEA, they recommended routine use of this kind of intraoperative completion studies, especially angiography and ultrasound sonography, strongly recommended. So today we are doing we can do some intraoperative completion studies, but some limitations also exist. For example, digital subduction angiography DSA is invasive because we should use catheter, and also this is a 2D images, so we can get only 2D images, no 3D dimensional images. And also by using ultrasound, This is easiest and least invasive imaging, but we cannot get also 3D dimensional imaging, only 2D, and we cannot find that observed distal internal carotid artery, only on-site image we can get. To solve these problems, we are now using 3D CT angiography in hybrid OR system. So in these systems, no catheter necessary, only intravenous injection of contrast medium, and 3D CT angiography can be obtained with hybrid ORs. This is how we do it in hybrid OR system. We are using a robotic system, and the patient cannot be moved to the CT gantry or MRI or so patient are set as they are, and CT angiography devices can come towards the patient site, and by getting rotational images, we can clearly get this kind of 3D images, only injecting by the intravenous, not the catheter, injecting contrast medium. So this is how we get 3D CTA in hybrid OR system. There are some representative cases on the CTA. And so the technical tips to get this kind of quite good quality images is to do test injection at first. So we first injected 10 milliliter or 15 milliliter contrast medium. So to get to measure the arrival time from the catheter to the from the intravenous catheter to the carotid artery, because it is different in each cases how long it needs to reach contrast medium from the venous line to the carotid artery. So at first we measured it, and after that, by referring this arriving time, we can get this kind of 3D CT angiography. So we applied 35 cases between last 2 years, and all cases we succeeded to get these images. And the contrast medium totally approximately 100 millimeter required, but time required to get this 3D CT angiography is 20 minutes approximately. And by doing this intraoperative imaging, we experienced two complications, two reoperations, one by rebleeding, one marrow stenosis, I will show. In case one, 81 years male with TIA, transient ischemic attack onset. He had left side calcified carotid stenosis, and we did CEA as a usual manner by after removing the plaque like this. And we don't use the patch graft. We prefer to close the vessels with primary closure fashion. And after closing the vessels, we did 3D CT angiography, and as you see here, there's a small venous pool, small poolings. By checking the artery just after this imaging, we have minor bleeding from the suture site. So this stenosis, we added some stitches. Here is a bleeding point. So we added 2 stitches to stop bleedings. So I thought without this imaging, we may have had post-operative bleeding on the suture site. So it could prevent this kind of complications. So added 2 stitches and get good hemostasis. This is one case. And the other case is a 55 years man with minor stroke on his right side. and he had a very fragile carotid plaque in his right carotid arteries. So this symptomatic carotid stenosis could be treated by CEA. And after removing the plaque, we can get this kind of 3D CT images like case 1. But getting 3D CT images, by getting this 3D CT images, we still have found some residual stenosis. Sorry. Here is the residual stenosis. So we checked the suture site, and some malsuture, some stitches involved the adventitia too much. So it could induce the narrowing after the CEA. So we reopened the suture and redid the primary closure again and rechecked the 3D CT angiography. And after all, this stenosis was resolved. We can get better outcomes. So this is how we did it in carotid artery endarterectomy CEA surgeries. And we also could apply this technique to the clipping, cerebral aneurysm clipping surgery. For example, this is a little bit complicated ACOM aneurysm. This is unruptured cases, 42 years male. And according to these kind of imagings, we prefer to treat it with clipping, not by endovascular surgery. By approaching with interhemispheric approach, we expose this aneurysm fully, and the clip was placed with multiple clip method to close the neck with 3D fashions. After completion of the clipping, we checked the 3D CT angiography, like CEA surgery, only with intravenous injection of the contrast medium. So we can get this kind of clear images by the intravenous injection. So this is a completion study, and we can close the suture, close the wound without any problem. So, but sometimes we have some problems. This is also the ACOM aneurysm cases. We did clipping, like case 1. Interhemispheric approach was chosen to expose the aneurysm from with the 360 degrees, and the clip was pressed to the neck, and ICG was also done to check the residual flow inside the aneurysm. There was no residual flow inside the aneurysm, and place another clip like case 1. And, but after completion of these 3D images, we still found a very small residual flow inside the aneurysmal sac, aneurysmal dome. So after this 3D CT angiography, we rechecked ICG again, but there was no flow, but slightly residual flow maybe, but the aneurysm wall was a little bit thick, so we cannot find out the residual flow closely, precisely with ICG. So after all, we placed some additional clips to get complete obliteration of the aneurysm. So for the aneurysms, we did 83 cases. In all cases, we succeeded to get these images, and time required for these images was approximately 20 minutes. And so we experienced 3 re-exploration cases, 1 residual flow, which I showed in the last cases, and some neck remnant and some stenosis of the parent artery. In these 2 cases, we are required to reclip the reposition of the clips. So according to the literature, intraoperative 3D images in CA was reported in 1 article, but these articles, they used to CT, intraoperative CT devices like this. The patient should be moved to the CT gantry. And this is not an angiography device, but CT devices. So they didn't measure the arrival time in each cases. So they said they experienced approximately 70% cases they cannot get this kind of good quality images because of the time failure, because of timing failure. But using this angiography hybrid OR system, we can measure the arrival time by the test injection. So in all cases, we can get good 3D CT images. But of course, we require approximately 100 millimeter of construction agent. So it is not suitable for the older patient with chronic kidney disease, chronic renal failure. And of course, we have some additional time to get these images. In conclusion, 3D angiography by intravenous contrast medium using the hybrid OR devices enables simple and clear images evaluation and is considered to increase surgical accuracy in cerebral vascular surgery. Thank you for your kind attendance. Thank you.
Thank you very much, Professor Hara. And do you know that the Chinese PRA General Hospital Department of Neurosurgery, which is our department, is the first institute in China to perform the CEA surgery. So Professor Xu is one of the pioneers in China for the CEA operations. So I want to invite Professor Xu to give some comments on this nice talk. Thank you.
Well, excellent talk, especially for the intraoperative imaging for the cerebrovascular disease or CEA. For example, the aneurysm clipping, and also to find out whether there is a residual or remnant or stenosis of the vessel. So I think that the main reasons to use this is first of all, is very simple. Compare with catheter required during the surgery. And secondly, it's very quick, especially for the CEA. It's very clear to find out the surgical outcome immediately. So my question is, compare with other techniques, for example, intraoperative MRI. So how this doctor to say that, yeah.
Okay, and of course, if we get much better images, for example, vessel thickness or cerebral infarction after CEA, intraoperative MRI may be beneficial. But if we use, try to use intraoperative MRI in CEA patient, we should move the patient into the MRI devices during surgery. It is sometimes quite time-consuming and sometimes quite need some effort to get these images. So CEA is a very established surgery. So and also, even though if we can find out some infarction in the brain after CEA surgery intraoperatively, we cannot solve the problem during surgery. So for this CEA surgeries, I think intraoperative MRI is too much for the evaluation. So CT angiography or cassette angiography or ultrasound is enough, I think.
Okay, so in our hospital, we use the flying MRI. So that means the patient do not move. We just move the machine, just like your CT. So anyway, we use some equipment to help us to have a very good surgery. So that is the point. So congratulations for your good presentation.
Thank you so much.
Thank you very much. Professor Kato, could you please give some comments on this novel technology application for CEA? Thank you.
Thank you very much, Professor Hara, because he replaced the clip once that he checked the 3D CTA intraoperatively. I think it's a very high advantage for the patient because it very shortened the time for the surgery, I think. So I think that means we should follow his advice, I think. Thank you very much for Dr. Hara.
Thank you so much.
Please.
Thank you very much. I wanna tell you guys a great news, ladies and gentlemen. We are just making a new record. So just now we calculated. We got a number here. Now we have 11,283 audiences watching our program on the online Chinese platform, which is called 脑议会. This is a single platform number. So I'm not sure. I don't know the number of audiences who is watching on YouTube channel, but I guarantee you that's a new record. So congratulations to everyone, and thank you very much for your effort.
Especially thanks for the Japanese colleagues.
Thank
Yes.
you so much for your great effort.
Okay, Professor Nakahara, could you please share with us your presentation now?
I feel very sorry about
no
trouble
problem.
on my computer. I think I'm okay. I stopped the pre-recording video, but I talk by myself. So my talk is regarding the endovascular treatment for the acutely ruptured cerebral hernia, recent trend in Japan and in global. Yes. Endovascular treatment with the ruptured hernia started early in 1970s. So after that, many efforts have been done by the many neurosurgeons and endovascular physicians. And the GDC development of the GDC was approximating. And after the result of ISAT study, these two things were very strong driving force to shift to the endovascular therapy from the direct clipping since the year 2000. But there was still a limiting factor such as the recurrence after the coagulation, and it may cause the rebleeding. So we need to do additional treatment, retreatment. So these were the limiting factors for us as an endovascular physician, neurosurgeon. So where we are now, after the 20 years since the introduction of the coil embolization for the ruptured hernias. Let's check the Japanese Stroke Society guideline published 3 years ago. There is a description that both craniotomy, clipping, and endovascular treatment, both are very good selection with the comprehensive consideration. And also the guideline says that we have to pay attention to the recurrence and recanalization and the regrowth. But in Japanese guideline, the description is very mild and not went into the very precise points. In contrast, American Heart Association, American Stroke Association guideline is very precisely describing about the endovascular treatment. Yes, in AHA guideline also they mentioned that both clipping and coiling, endovascular is recommended in many cases, but endovascular is better considering about the improved the 1 year functional outcome compared with the clipping. So this is very different from the Japanese guideline. And also the AHA guideline says that we can think about the staged treatment followed by the initial target of obliteration, embolization by the coil embolization. This is very different from the Japanese guideline. They propose the possibility of the staged treatment. And also they mentioned about the stent-assisted coiling and the flow diverters. Both of these are off-label treatment in acute phase of the subrecurrent hemorrhage. But in a particular situation, they says that it may be a reasonable choice to use the stent-assisted or flow diverter treatment for the ruptured cerebral aneurysms. And also they mentioned about the effectiveness of the intrasaccular flow disruptors. I will talk this about later. It's woven and bridge, and also the possibility of the surface-coated flow diverters in the acute treatment for the ruptured aneurysm. This is the trend of surgical treatment for subrecurrent hemorrhage, ruptured cerebral aneurysm in Japan. And recently, the number of the direct surgery for the ruptured aneurysm is coming down like this. Now we are in 2024, and treatment by the endovascular surgery is gradually increasing. So I think now maybe 50-50 or maybe 60% by endovascular surgery in Japan. And how about the Europe? This is a report from the Helsinki University, Finland. As you may know, that Finland is in Finland they did so many clipping. It's very famous by several excellent neurosurgeons. But the number of the surgery is coming down like this, and the crossover point was at 2018. After that, the proportion of the endovascular treatment is increased like this. And recently, only for the MC aneurysm, they are doing their clipping. So it's a very dramatic change in the Helsinki University. But in this paper, they said that whether this shift has affected the long-term safety and the patient outcomes, this should be discussed in the future. So this is a report from the United States. Also in the United States, both ruptured and unruptured aneurysm, more than 70% has been done by the endovascular therapy recently. This is 2014, so I think the number of the endovascular treatment might be increased more and more. And in this paper, they said that the introduction of the endovascular treatment made a significant reduction in the length of the hospital stay for the ruptured aneurysm. I mean that introduction of the endovascular therapy brought improvement for the patient care for the ruptured cerebral aneurysm, acute subrecurrent hemorrhage. Of course, it is very important, as I mentioned, and it is written in the guidelines. The re-rupture problem is a very big issue. But in contrast, if the recurrence or re-rupture problem is solved much more cases will be done by the neuroendovascular therapy instead of clipping. So what is the key to this issue? This is my team for the 9 years since 2015 in strokeology department of the Fujita Health University main hospital. After the 2020, the number of the endovascular dramatically increased. And for these 2 years, more than 80%, maybe almost 90% of the cases has been done by neuroendovascular therapy. What was the what occurred in 2020? This is the evolution of device of the neuroendovascular therapy after 2000. Several stents or flow diverters has been introduced in neuroendovascular therapy, but one of the very epoch-making devices is a new generation of flow diverter, and then the intracircular flow disruptor. It's a woven end bridge. It's called briefly 𝑉EP. Both of these devices has made a dramatic change in treatment of the neuroendovascular treatment. Of course, flow diverter and also stents are off-label in for the acute subarachnoid hemorrhage treatment because they require the pre-treatment antiplatelet drugs. Usually a dual antiplatelet drugs. It's called DAP. In acute treatment, the patient has not received these kinds of DAP, so stents or diverse are off-label for acute treatment. So how do we apply these technologies to improve the treatment of acute subarachnoid hemorrhage patient? So there is some answers for this issue. The left side is a plug and pipe strategy paper published in JANIS in 2019. In this paper, they did initially plug the rupture point of the aneurysm by partial coiling, target coiling. And after maybe several weeks, they applied staged flow diverter treatment after they put the dual antiplatelet agent for the patient. And the right is the same kind of reports, also by in this team. They did the coil embolization for this very difficult large aneurysm initially, and then after maybe several 2 or 3 months later, they did flow diverter treatment, staged flow diversion, with a very good result. Also in Japan, by the Yamazaki and the Fujinaka group in Osaka, they did the staged treatment for the wide net ruptured aneurysm with the initial target coiling. And after that, they did in some patients clipping, in some patients stent assist coiling, and very few, but they did the flow diverter treatment. So about the 10% of their cases, they applied the staged treatment after the maybe 2 or 3 months after the initial treatment. This is our case. This is a 33 years old male. Subarachnoid hemorrhage was not very strong, very severe, so maybe we could do a clipping in the initial stage, but in this case, we did the target embolization here, like this, coil embolization to the ruptured part initially. Then after 3 weeks, we did the interhemisphere clipping by the interhemisphere approach. This was a superior projection, but so surgery might be a little bit difficult than the standard treatment, standard surgery. So it was a very nice case. Patients did very well. Another case, this was 59-year-old female, and this case was also SAH, subarachnoid hemorrhage was mild, but the aneurysm was very large. So maybe we can clip, but we can imagine that it's very difficult station of the anterior choroidal artery. So we did the coil embolization for the most parts of the dome, and after the initial treatment and in the chronic stage, we put the flow diverter to get very nice result. It's complete cure after the 1 year. And also, flow diversion is the direct flow diversion. The diversion is the next issue. Now, flow diverter with anti-thrombogenic surface modification has come to us. One is pipeline flex with shield technology. In this flow diverter, MPC copolymer is coated on the surface of the flow diverters. And another one is FredX. Also, this was coated, surface coated. It's just come to Japan, and using the new flow diverters, we can use the flow diverter in acute stage subarachnoid hemorrhage, maybe even in a distal narrow parent arteries, and also with monotherapy using a novel antiplatelet agent such as prasugrel or ticagrelor. This is such a paper from Australia with a very nice results. Of course, they are applying this technique initially for the very difficult aneurysms, such as for the form of blister aneurysms. This is our case. This was a very poor grade patient, 80 years old female. This was a very dangerous, very difficult dissecting aneurysm of the internal carotid artery on the medial side, medial wall. I was very, very afraid of the rupture during the treatment. So I initially put the coil and the stent, stent and the coil to secure the to stop the bleeding during the treatment initially, and then after that, in a single session, in the same session, I put the two pipeline shield by overlapping fashion. We did the stent-assisted coiling and flow diverter treatment in a single session. Staged treatment and surface-coated flow diverter treatment will be the one answer to improve the result of acute treatment for the side wall aneurysm by endovascular strategy. Another answer is intrathecal flow disruptor woven end bridge for the bifurcation type or a terminal type aneurysm. As you may know, woven end bridge wave has been introduced already in 13 years ago, 2011 in Europe, and this is a kind of flow diverter put inside the aneurysm, and this device is not deployed inside the parent artery. So basically, we don't need to use the antiplatelet agent. So this device is on label, approved by the insurance, even for the ruptured aneurysm. By this very dense mesh of the threads inside the aneurysm, it will provoke the endothelial growth at the neck of the aneurysm, bringing the complete cure of the aneurysm at the neck, like this. So in the last 3 years, we have done 120 cases of treatment in the stroke department in the Fujita Health University Hospital, and among these 24 cases was treatment in the acute phase of the subarachnoid hemorrhage. This is a summary of the clinical cases with all of the cases, 120, and the result was very nice, even compared with the very famous studies in Europe and the United States. And this is the ruptured case, and about 20% was the acute treatment case. This is one case of our series, a 50 years old male with picture type 3 subarachnoid hemorrhage. The anterior communicating artery aneurysm projecting superiorly. Of course, trained physician can clip this, but not very easy. Maybe many of the expert neurosurgeon can clip, but in this case, we put the woven and bridge web inside the aneurysm like this, and after the treatment, the aneurysm was gone, and long-term follow-up angiography confirmed the complete closure of the aneurysm, even after 1 year. So it's a very nice case. This is a summary of our acute cases in which the University of Strokeology. It's a result of 17 cases, and grading of the subarachnoid hemorrhage is like this. So I includes grade from grade 1 to grade 4. The size of aneurysm is about 6 millimeter, and many of these are very broad neck. And ACOM, CPC, and MCA, and vaginal tip are the predominant location. And treatment was successful in all cases. The very good point is that the treatment time is very short, a little bit more than the 1 year, and also very quick treatment, and very simple. And the intraoperative rupture was not experienced in any cases. And very important is rebleeding after the initial treatment was not observed in any cases. But we need to pay attention to the, again, retreatment. We experienced one case of retreatment. In this case, woven and the bridge could not cover the rupture point near the neck. In these cases, we have to be very cautious if we should apply the web treatment or maybe any other endovascular strategy or maybe clipping. So web treatment or endovascular treatment is not always perfect treatment. So we have to be very careful if it is very good for these patients or not. But anyway, web for the acutely ruptured cases regarding this issue, 𝘓𝑒𝑟𝑎𝑙 study. This is a very famous study for the acute treatment using the web device with a very nice result with a rebleeding, rebleeding rate was 0%. But they also in this report they experienced retreatment in 10%. So again, we have to be very careful for the application of this device for very difficult cases. Very important is that they are using Web 17 system. What is a Web 17 system? Currently in Japan, we only have the Web 21 or more large web systems only. But in many countries outside Japan, already a Web 17 system has been introduced. Using these devices, we can treat more small aneurysm with very narrow microcatheters. And this is, we are waiting for this new devices now. Maybe it will come in 1 or 2 years in Japan. This is the last case in my presentation. The patient was a 96-year-old female, very elderly patient, but here she was independent in her family, and she came with a severe headache and a right oculomotor palsy, and the grade was very nice. Initially, I didn't think it was bled, but we found a right ICP aneurysm like this with high aspect ratio, and MRI showed the very small subarachnoid hemorrhage in the same hemisphere. So we decided to treat her by the endovascular therapy and by a distal transradial artery approach. So the approach side was not in the groin, but from the right wrist, right hand. with a very non-invasive approach like this. And then we put one small wave at the bottom of the aneurysm without occluding the tip attaching to the oculomotor nerve. It was the treatment time was very short, and after several days, she went home without neurological deficit. This is MRA taken after 1 month in a local hospital. You can see the no aneurysm here. This is a PCOM, and she's doing very well now in her home. So, in my experiences, about 70% of the ruptures or unruptured aneurysm are now treated by the endovascular therapy, particularly in these 2 years, 1 or 2 years. Then the penetration ratio is becoming higher and higher, about 90%. And for the bifurcation aneurysm recently, even for the ruptured aneurysm, about one third, 33% have been treated by the woven and the bridge. And for the unruptured aneurysm, many cases are treatable by these new devices. New generation surface-coated flow diverter is coming soon in Japan. Also, a new generation intraocular flow device, flow disruptor other than woven and bridge may come in several years. So by applying these new devices to the acutely ruptured aneurysm, more high percentage of the penetration of the endovascular therapy will be in Japan, maybe in the near future. I'm not sure. This is the last slide. The proportion of endovascular treatment in surgical management of the subarachnoid current hemorrhage due to ruptured cerebral aneurysm exceeds 70% in some parts of Europe and the United States. And as the rate of endovascular treatment increases, the overall outcomes for ruptured cerebral aneurysm appears to be improving. So this improvement is driven by new strategies like staged treatment strategy, introduction of new devices such as surface-coated flow diverters and the intracerebral flow disruptors, including woven and bridge. And as next new generation devices are used more widely, endovascular treatment outcomes will be continue to improve. So neurosurgical department at stroke centers around the world will need to adjust these changes. Thank you very much. Thank you very much. Thank you, Professor Kato.
Thank you very much. Thank you very much for your nice presentation. Professor Kato, could you please give some comments for this?
Okay, thank you very much. Thank you, Chen. So I think Professor Nakahara made a great presentation. So thank you very much. And since the Nakahara Sensei came to our department actually this April, so almost all aneurysm is treated by endovascular. So no more chance for the clipping surgery. I think. So I think even the MCA and also the ICPC, of course, almost all, of course, the posterior circulation is treated by endovascular. Especially Nakahara Sensei that he mentioned about the web is very, I think, outstanding. I think a device. Because of now in Japan, is more and more senior patient is increasing. So for those patients, is I think maybe the old treat by the web. I think in the future because it can be treated also the rupture case. So maybe of course the China is far advanced endovascular treatment comparing with the Japan. I think so maybe I think in future maybe. Not only the open surgery, but also the endovascular treatment. We can collaborate with China, especially Dr. Chen's hospital and ours. I thank you very much.
Thank you.
Wonderful talk. Congratulations, Dr. Nakahara Sensei.
Thank you. It is well known that Professor Bannan Xu is a very famous specialist for cerebrovascular diseases. Professor Xu, could you please give some comments on this talk? Professor Xu, your microphone is not on.
Well, it is very interesting topic, coiling and clipping. And for the trend, just like Dr. Katos asked, nowadays in China, of course, the coiling is going up and clipping is going down. That is a trend. I don't have the exactly the number, but that is a trend. I think this is similar to your country or any other countries in the world. So because time limited, I just leave the question for my Japanese friend, colleague. And this question also for the presenters and also for the Dr. Kato, because Dr. Kato is really a vascular expertise in this world. The question is, first of all, what is the room leave down for the open surgery, for the microsurgery in the future? Talking about the aneurysm only. So what sort of aneurysm should go to the clipping or some other treatment, not the coiling? That is the first one. And secondly, I noticed just now you talking about the bifurcation aneurysm, and 6% of them go to the coiling. You say this bifurcation is MCA or including all of the bifurcation, for example, basilar tape? So that's the two questions.
Okay, thank you very much. For
finally, what is the exactly ratio nowadays in Japan for coiling and clipping?
加藤先生、私からでよろしいですか？
もちろん、もちろん。
Thank you very much for the questions and comments. Still difficult for the endovascular treatment is one now large or giant aneurysms, and also with partially or the much thrombosed. This treatment of endovascular treatment, endovascular therapy for these aneurysms is still very difficult. In this difficult aneurysms, often we need bypass surgery, such as the posterior fossa bypass or high flow bypass. This is the Professor Takaki Hara is the expert in this territory, but still bypass surgery requires is a very important technique for these formidable, very difficult aneurysms. And according to the second question, of course, bifurcation or terminal type aneurysm includes 𝑃𝑟𝑜𝑓, MCA, isotope, and basal top, and also some of the ICPC aneurysms. These are very good for the intrasaccular flow disruptor, and new generation intrasaccular disruptor will come, such as 𝘓𝑒𝑚𝑖𝑡𝑠 or 𝘓𝑒𝑟𝑎𝑙. Already these two devices have been using in Europe in 1 or 2 years ago. So these new devices will come to East Asia soon. So for many bifurcation aneurysms, we can use these devices maybe in several years.
Okay, in condition, only talk about the MCA aneurysm. coiling or clipping in your country nowadays?
Still, many physicians are doing the clipping. In some limited institutions and physicians, endovascular treatment used. But simple coiling for the MC aneurysm is not a very good choice because of the recurrence or the rebleeding. I think intrasaccular device, yes, I mean the wave is very provides a high durability. So I prefer to use this, but I don't want to treat the MC aneurysm with the coils.
Well, Dr. Shri, thank you very much for your nice comment. But I'm not the endovascular surgeon, but my feeling, because for the patient is a less invasive treatment with endovascular, because maybe it will finish in 1 hour, but the open surgery it will take 3-4 hours. And also, I think where the Professor Nakahara sensei presented the last part, I think web is very suitable for the MC aneurysm. So that is a last territory for the open surgeon, but now it's for the endovascular territory now. It can be applied, even the ruptured case, I think. But sometimes my feeling is some shape and maybe some small volume one cannot be treated with the new devices. But in future, it will be treated the new devices, I think. What about the China?
Nowadays, very little rooms for the open surgery, but I don't think the surgery will disappear. It still have play an important role in the aneurysm surgery. For example, aneurysm isolation plus bypass and can deal with some complex aneurysm. So we focus only on the complex aneurysm for the open surgery nowadays.
Thank you very much. Dr. Hara Sensei, do you have any comments?
Thank you. To my impression, the direct surgery clipping, the number of clipping is decreasing also in the future in the Japan. But I'm a direct neurosurgeon, and I believe the long-term outcome of the clipping, especially for the MCA aneurysm, clipping is not so difficult. Until the long-term outcome has shown, will be shown in the future by the WEB, intra-aneurysm, circular aneurysm device WEB, I believe the efficacy of the clipping. I will continue to do clipping, especially for the MCA aneurysm. It's my personal opinion. Thank you.
I totally agree with you. And now, for example, for the posterior circulation aneurysm, of course, go to the endovascular treatment first. But for the MCA, you know, it's quite easier to expose and clipping. And also, it's a very lower rate for the residual or remnant later on. So, of course, we go to the surgery. But anyway, you know, I learned from you because I spent some time in Japan from 1980 to 1990. So I learned aneurysm surgery from there. So take this chance. I would like to say my great appreciation to Japanese cerebrovascular surgeons.
So which university you spent?
Juntendo University. Juntendo.
Juntendo. Oh,
Yeah,
Juntendo.
Juntendo. Yes.
First
Dr.
Ishii.
Sozo, Dr. Sato Sensei, Dr. Maida Sensei. You know, I learned a lot. Thank you
𝑚𝑖𝑗
very much.
𝑚𝑖𝑗.
And also in that time, I visited Nagoya to the
Nagoya
Dr.
University.
Sugita,
Sugita
Dr.
sensei.
Kobayashi. That
Kobayashi
is
sensei.
really the great talent for the aneurysm surgery.
Yes. Thank you very much.
Thank
Okay,
you.
it's really a small world, and so far so good. And I got latest number. Now we have 12,139 audiences. That's a new
Great.
record. So
Thank you very much.
because our time is limited, so we are moving to the closing. So I wanna invite Professor Kato, the lady first, right? I want to invite Professor Kato to give us the closing speech first. Thank you.
So thank you very much. This time is the President Neurosurgery Intercity Train. I think we had a very great conference because the 4 speakers were excellent speakers and very variety topics. So we learned a lot from them, I think. So maybe in the future we have more collaborate with university or with Chinese society. So maybe we can have more advanced technique for that, not only for doctor but also the patients. Anyway, thank you very much for this occasion. So maybe next time I look forward to the next time. Thanks so much.
Thank you. Okay, next I want to invite Professor Bainan Xu to give us a closing speech. Thank you.
First of all, I would like to say there is no border between the countries for science. And secondly, learning, communicating, and sharing each other. That is always for the progress of the academic or clinic, whatever. So I learned a lot, and I hope this program can keep on going in the future. So today I especially thanks for the Japanese friend, and because all of you have given us very nice talk, and we learned a lot. Thank you very much. And also I would like to say all the audience today, at the beginning I say we expecting the audience will go over the 10,000, and finally now it's 12,000. So thanks for the audience to like us. Thank you. Thank you very much. Have a good one. Have a good night.
Thank you so much.
Thank you.
Okay,
Thank
good
you
night.
very much. Okay, thank
you,
you
Chen.
for
Dr.
all the
Thank you
speakers,
so much.
all the VIP guests, and all the chairpersons. And thank you for all the audiences. See you.
Thank you very much. Bye bye.
Thank you.
Thank you
Bye bye.
very much.
See you again.
See
Bye-bye.
you.